The second population seen in leukoerythroblastosis consists of immature granulocytic precursors, early myeloid forms such as myelocytes and metamyelocytes, cells that under normal conditions belong entirely within the marrow and are released prematurely here under the same conditions of architectural destruction. The co-presence of both nucleated erythroid precursors and immature myeloid forms simultaneously on a peripheral blood smear is what defines leukoerythroblastosis, and this finding should immediately prompt clinical investigation for a space-occupying marrow lesion, whether neoplastic or fibrotic in origin. To crystallize the central concept, myelophthisic anemia is fundamentally a space problem. The marrow is not empty, as it is in aplastic anemia, and the precursor cells are not lacking building blocks, as they are in iron deficiency or megaloblastic anemia. Instead, the marrow is occupied, but by the wrong tissue entirely. That tissue, whether malignant tumor or fibrotic scar, physically destroys the hematopoietic microenvironment, forces premature egress of immature cells into the circulation, and produces a clinical picture of pancytopenia accompanied by the hallmark leukoerythroblastic blood smear. Recognizing this pattern on the peripheral smear is the key to identifying marrow infiltration before more invasive investigation is undertaken. In summary, leukoerythroblastosis is defined by the presence of immature myeloid cells and nucleated red blood cells in the peripheral blood, often accompanied by teardrop-shaped red blood cells, dacryocytes, and most commonly indicates bone marrow infiltration or fibrosis, such as in primary myelofibrosis, PMF, or metastatic malignancy. It serves as a key minor diagnostic criterion for overt PMF, but can also result from other marrow-replacing processes like metastatic carcinoma, lymphoma, granulomatous disease, severe infections, or marrow stress, and is seen across ages, including in specific pediatric syndromes like transient abnormal myelopoiesis in Down syndrome. Classic laboratory findings. Peripheral smear shows nucleated RBCs, immature myeloid precursors, and often teardrop RBCs. May also see giant platelets and anemia. Primary myelofibrosis association, leukoerythroblastosis, is a frequent finding and forms a key minor diagnostic criterion in PMF alongside anemia, splenomegaly, and elevated LDH. Mechanism of occurrence reflects bone marrow infiltration, replacement, or fibrosis, leading to myelophthisic and the release of immature precursors into circulation. Other possible causes: metastatic carcinoma, lymphomas, severe infection, particularly sepsis, granulomatous disease, for example tuberculosis, and congenital disorders, for example trisomy syndromes, can also cause leukoerythroblastosis. Workup recommendations. Bone marrow biopsy is indicated to confirm diagnosis and distinguish between malignant, fibrotic, infectious, or infiltrative etiologies.